A patient presents with a small, charred crater on their index finger. It looks like a minor injury, but just millimeters below that dry surface, the deep flexor muscles are swelling and graying into necrosis, surrounding a highly erratic nerve bundle. In the United States, electrical injuries account for approximately 1,000 deaths every year, leaving survivors with severe, long-lasting morbidities. Calling this presentation an electrical burn is a clinical misdirection. True thermal burns spread continuously from an external heat source. Electricity behaves entirely differently. The vocabulary we use often fails us here. Categorizing wounds as entrance and exit sites implies a clean, linear trajectory. Alternating current reverses direction 60 times a second. It does not travel in a straight line. The accurate term is contact points. These are simply the locations where the body completed a circuit with the electrical source. Standard thermal burn protocols rely on calculating the total body surface area affected. Relying on this visual assessment for electrical trauma will actively fail your patient, as the vast majority of the destruction is invisible from the outside. To effectively manage these patients, clinicians have to abandon surface-level paradigms. You must treat the patient's body for what it has become, an internal, highly conductive electrical circuit. The severity of deep tissue destruction is governed by two principles of physics: Ohm's law of resistance and the Joule effect, which dictates how electrical energy is converted into heat. Dry skin provides 100,000 ohms of resistance. When breached, current bypasses fat and bone, rushing into highly conductive nerves and blood vessels. By the Joule equation, this generates extreme heat that radiates outward, cooking deep muscle tissue while leaving superficial layers untouched. Heat generation only accounts for a portion of the observed damage. The current also causes electroporation, a microscopic, cellular-level mechanism of injury independent of thermal burns. The electrical field physically alters and tears open the cell membranes of muscle and nerve tissue, violently spilling their internal contents. This microscopic membrane rupture initiates progressive cellular damage. It triggers a delayed tissue death that will not show up on initial radiological scans or physical exams. A benign presentation on the surface is a trap. The most lethal physiological damage is cellular, delayed, and happening entirely beneath the fascia. Alternating current, or AC, is the standard power supply utilized for nearly all commercial and residential infrastructure. Even the low-voltage electricity powering these everyday household appliances is fully capable of causing fatal trauma in a fraction of a second. In North America, this current alternates at 60 Hz. This specific frequency interacts catastrophically with the human nervous system. When a person is exposed to an AC current of just over 20 milliamps, it crosses the threshold necessary to trigger involuntary tetanic muscle contractions. This diagram illustrates why victims frequently cannot let go of a live wire. The flexor muscles of the forearm are significantly stronger than the extensor muscles. The current forces both groups to contract simultaneously, resulting in a tightly clenched fist wrapped directly around the electrical source. This mechanism locks the victim in place, drastically extending the contact time. Returning to the Joule equation, heat creation is a direct product of current multiplied by contact time. Extended exposure causes massive deep tissue necrosis, even if the initial voltage was relatively low. This risk is magnified in occupational exposures, where linemen and construction workers often sustain prolonged contact with live infrastructure, leading to highly complex traumatic injuries. Systemically, this current disrupts the heart's electrical pathways. Alternating current frequently induces ventricular fibrillation, requiring immediate CPR and defibrillation to restore a viable rhythm. Low-voltage alternating current is highly lethal because its specific frequency overrides human motor control. It weaponizes time against the patient, keeping them attached to the source until they are cooked from the inside out. Direct current, or DC, presents a completely different pathophysiological profile, best modeled in the clinical setting by a lightning strike. A direct lightning strike delivers overwhelming physical force, carrying upwards of 100,000 volts of direct current in a single instant. Unlike the fibrillation caused by alternating current, a massive DC shock causes a simultaneous global depolarization of the entire myocardium. This sudden electrical overload stops the heart completely, resulting in asystole. Furthermore, lightning is not strictly an electrical event. The extreme energy displacement creates an explosive blast wave, superheating the surrounding air to temperatures approaching 50,000 degrees Fahrenheit. Because of this concussive force, clinicians must thoroughly evaluate these patients for associated mechanical trauma. Actively hunt for ruptured tympanic membranes and check for spinal fractures caused by secondary falls. Upon skin examination, you may observe Lichtenberg figures, distinct fern-like erythematous patterns branching across the body. While visually alarming, these are not thermal burns. They are temporary autonomic reactions in the skin that typically fade within 24 hours and indicate no underlying deep tissue destruction. A lightning strike operates on entirely different physics than commercial electrical injuries. It is a dual threat of sudden autonomic shutdown and extreme blast force trauma, demanding immediate, full-spectrum airway, breathing, and circulation resuscitation. In the emergency department, standard burn management guidelines collapse. Fluid resuscitation formulas tied to total body surface area are clinically useless when the skin remains intact while the muscles disintegrate. The true metabolic threat is happening inside the vascular system. As the deep muscle tissue breaks down from the heat and electroporation, it dumps massive amounts of the protein myoglobin directly into the bloodstream. As seen here, these large molecules travel to the kidneys and physically clog the narrow renal tubules. This heavy load of red pigment will rapidly induce acute renal failure unless the kidneys are aggressively and continuously flushed with fluid. Your immediate clinical target is strict clearance. You must titrate intravenous fluids to maintain an adult urine output between 75 and 100 milliliters per hour. This volume is effectively double the standard trauma baseline and demands continuous, precise monitoring via a urinary catheter. Lactated ringers should be administered at high volumes and maintained without interruption until the urine is visibly clear of all red pigment. In electrical trauma, fluid resuscitation is not determined by the square footage of the visible burn. It is driven entirely by the urgent requirement to clear toxic muscle breakdown products from the inside. There is a final, mechanical threat hiding beneath the surface: the deep fascia. These are the rigid, unyielding white connective tissue sheaths that encase the deep muscle groups of the extremities. The extreme heat and cellular electroporation trigger massive edema deep within these closed spaces. The muscle swells violently, but the fascia cannot stretch to accommodate it. As a result, the expanding muscle pinches off the adjacent arterial vessels. This sharply rising internal pressure chokes off distal blood flow entirely, creating a true compartment syndrome. You must perform hourly physical exams, monitor obsessively for loss of pulses, color changes, and altered neurological sensation. Once those pressures rise and blood flow decreases, there is no medical intervention that will reverse it. A surgical fasciotomy, slicing open the fascia to physically release the pressure, is the only definitive way to restore perfusion. Surviving the initial cardiac shock is only the first hurdle. Failing to identify and surgically decompress this invisible internal pressure cooker will ultimately cost the patient their limb.